machine is also a bi. So we got bi. Okay, biphasic. So why is it that a tens unit can work it for a quad, but I mean this unit can work a quad to get extension, but a tens unit can't?
Because of the strength,
Okay, so,
the power.
but can this do it?
Yes.
Yes. Okay. NMES? Okay. Okay, good. All right, let's move on. Polarity. What does polarity mean?
Either negative or positive.
All right, so if I'm doing a monophasic machine and I change it to negative, what am I doing to the treatment? I'm killing bacteria. But if I change it, I'm doing what?
Healing.
I'm doing healing, just with a button. Just with a button, okay? Intensity or amplitude. What can that do? Or what can that button cause or change?
Spasm.
Increase the tingling?
Tingling or twitch.
When I first turn it on, depending on the setting, but if I first turn it on, even if I have it on 250 microseconds and 50 pulses per second, when I first turn it on, the person is going to feel what? Sensory. Good. I have to keep turning to do what? Reach motor. Okay. But the button makes the difference between sensory or motor based upon if I turn it up. So if you say, I'm not getting it, I'm not getting it, I'm not getting it, you're probably not getting it because of what? You didn't turn it up. Now, let's say that you're working with quad lag and you turn up the intensity and you get the lag to, I don't know, negative 10 degrees of extension. And they say, that's enough. That's enough. That's enough. Stop. That's enough. What can we do to get full extension? It can actively help, yeah. I'm going somewhere else. But that's good. Reposition, give me some more.
Reduce the pause.
Let them get used to it.
Thank you. Let them get used to it. Come back and turn it up. Let them get acclimated to the treatment. Let them get accommodated to that. Sometimes you can't quite get what you want the first time. But if you come back, let them get used to that, then you can do that. Good. All right, treatment time. Now, if I have a 700C, that big gray machine, I turn the timer, what does that do? That starts somewhat of the treatment. We still got to do the intensity afterwards. But some of these machines, I can set the timer on here, and it still doesn't start the treatment until I do what? Till I press start. Good. Okay, so just know the difference between what certain things can do versus what it can't do. Intensity balance. You will probably see an intensity balance most of the time on what type of machine? Balance. Type of, what waveform? Monophasic. All right, so we have a machine back there. Let's say it's the 700, no, it's the 700C or the 500, and it has 2 leads that come out of one and 2 leads that come out of the other. And I can put some pads on the right side, and I can put some pads on the left side, but I can only turn one intensity up. And they say, woo! You say, well, what do you mean by woo? It's a little bit too much. A little bit too much where? It's a little bit too much on the right. Well, how's the left? Not that bad. So then I can go to the intensity balance, and I can turn down off of one side versus the other, still have the same intensity for the opposite side. So the balance balances out how much the person is going to get from that one jack. I can give more to one side and less to the other. So that's the balance or the percentage. All right, mode. Mode. All right, continuous. What does that mean? Constant tingling. What does it say on this machine that continuous means? Anybody know?
Yeah.
Constant. Good. Anybody remember what it says on, it's a stackable unit back here. It was for home assignment. Pulsed. Pulsed. All right. Good. Surge. What does that mean? Synchronous. It means build up one direction of activity for a period of seconds on versus a period of seconds off. Okay. Reciprocate.
Alternate.
Alternate. Good. Alternate. All right. What does that mean, though?
The bidirectional between two motions.
Bidirectional. Neat. Go on, Chef.
Different direction.
I don't know all them big terms. Okay. Note alternate names. So here are some alternate names for the pulse rate. So we have pulse rate. We have frequency. What's the other names that we named earlier? Cycles per second, pulses per second, hertz, pulse rate. Good. And then you have pulse width and pulse duration, both the same. Now, with the pulse rate and the frequency, what abbreviation falls with that again? What abbreviation falls with this funny looking M or the regular M?
Micro.
Does it fall with both of them or one of them?
No. But the pulse rate.
Pulse width. For pulse rate?
For
Microsecond is
It doesn't fall with either.
What?
Which one?
Microseconds?
Pulse per
Does it
second.
fall with the frequency?
No.
Milliseconds, does it fall with the frequency?
No.
No. Okay.
Pulse per second.
Good. Pulse width and pulse duration falls with the funny looking M and the regular M. Good. All right. Now, what is ramp time?
Less than half of surge.
Okay, so ramp time, somebody said less than half of the on time of surge. Okay, now, let's give a definition of what ramp time is, though.
It's a gradual rate.
It's a gradual. It controls
During surge.
And we could put it on a decrease if we wanted to, of a
surge.
surge or
reciprocate.
reciprocate. So we can control how fast it goes if we just put a ramp time on. Or we can control how fast it goes if we just put a ramp time on. Okay. All right, good. Let's go second column. E-Stim words. All right, so based upon the strength duration curve, and I think we hit this earlier, microseconds will be earlier in the strength duration curve. Milliseconds will be later in the strength duration curve. All right, electrode types. What types of electrodes are out there?
Yeah,
Stickies,
Oh.
Rubber.
Non-sticky.
So, if I have a pad that has grit or has a texture to it, what can I use to treat with this?
Gel.
Gel?
Water.
Water. What's the problem with water?
It evaporates.
It evaporates, so I want to make sure I don't use it for
Motor.
motor, but I can use it for sensory. Good. Okay. All right. What is a channel or what is a lead? What does that mean?
Channel. A lead is a wire.
The delicate wires.
Lead is a wire.
Lead of the delicate wires. Channel is just what everything comes out of, or a jack. Okay. Channel 1, channel 2. All right. It's just a jack of what everything comes out of. All right. What is an active pad? What does that mean?
Is when you feel
Where the current
Where-
is felt.
Where the current is felt.
yeah.
Where the energy is felt. What about a dispersive pad?
It's convey the current to part.
Where
After.
the activity
No
is
feeling
felt.
under the pad.
No feeling under the pad. Okay. What makes it a dispersive pad?
Because it convey the current to active.
Twice the size of the active.
It's more than 2 times
Oh,
of the active
I was
pad.
going to say that next.
that's a function.
Okay, now, what constitutes a circuit? Don't give me exacts. Give me globally. What makes you have a circuit?
When you have two
Same channel.
pads, equivalency price between each other.
2 pads for some work.
Equal size, with equivalent size.
Does equivalency matter?
No.
No.
Because you
What?
have this
Two the same.
I just need 2 pads. I don't care what size they are.
On the same channel.
On the same channel.
All right.
Right. I don't care what size they are. I can have a little teeny weeny thing there.
Wow.
Same channel. Do I have a circuit?
Yes.
I sure do. I sure do. I sure do. I sure do. Yeah, you know that word, Sean. Okay, good. All right, so now we're getting deep. Detail. What makes it monopole?
Dispersive and active.
One dispersive, one active. And you're going to feel it out of the active or the smaller pad. Okay. What makes it bipolar?
When you feel same side.
2 active pads. Now, what, do you see what it says there? It says close size. Is this
No.
bipolar?
Yes.
Why is it bipolar?
Because it's not twice the
It's
size.
not, but it's not the exact same size either.
So couldn't you run bipolar with a dispersive pad and a very small active pad if you had a biphasic machine?
You can do.
It still would be bipolar, it wouldn't be correct.
So if I did, I think I know where you're going. So suppose I did. Suppose I did this and this with a biphasic machine. What is this?
That's
It's a monopole
monopoly.
setup.
But it would be bipolar because you're running an alternating current through it, right? I mean, it wouldn't be
It's a
monopolar.
biphasic current that's going through, but remember, polar always refers to the pad placement. So the pad placement is bipolar. You just have the alternating current coming through one feeling of a pad. Yeah. So nothing changes. The pad placement doesn't change because or the phase doesn't change because you change the pad size. Okay. It's still the same thing, regardless of what you put there. All right, let's see. Okay, quadpolar.
4 pads, 2 channels.
4 pads, 2 channels,
Same size.
crisscross.
Crisscross.
Good. Crisscross. Okay, good. Now, milliamps or volts. Most of the time we're concerned, well, really only time we're concerned with knowing about what the exact number is for the milliamps is usually when we're dealing with a wound care protocol that has a particular number that they have researched and found that this works good for a wound. Okay? So, if you want to look at really a definition, per se, of milliamps or volts, it's really a force or pressure of electricity. So when we turn up the intensity or when we turn up the milliamps on that machine, it's just a force or pressure of electricity that person is given. That's all they get. All right? But otherwise, the exact number we don't care about. What do we care about, though? What they feel, what the patient says. Can we get the movement? If we don't get the movement and we say, okay, your leg is at 45 degrees of knee extension, we're trying to get 0, and they say, turn it down! You can't say, we're sorry, but we're trying to get knee extension, so you just have to deal with it. So get over it, stop whining, and just move on. You can't say that. All right. Sensory. Where does sensory fall on the strength duration curve?
Earlier.
The first curve. The first curve. Now, in the next book, we're going to get into sub-sensory. So when we turn up the intensity, we're not going to touch that first line. So they won't, for the most part, be able to tell us that they have tingling. And you have to almost go back to the ultrasound stage and just say, well, it's working, but I know you can't feel it, but it's working because it's in the sub-sensory, mental alignment or physical alignment that they can tell you that they're actually feeling. But it is on. It is on. All right, so it's reaching those fibers just below the sensory level. Okay. All right, taps. What type of pulse rate could we turn the machine to get taps? 2 to 4.
Or
How do we get taps from a machine versus, I put the pulse rate at 2 to 4. What do I need to put the pulse width at
50.
to get taps?
50.
50 or below or something like that. Okay.
Taps?
Taps, not twitch.
That sounds true.
Okay. See, I can get this. So I want the pulse width low. If I get the pulse width too high, it's going to do what?
Twitch.
Okay. So I don't want to do that. So how do I get tingling? Okay. So I turn the pulse width up to 50. I have the pulse rate
200.
on
80 to 100.
100. Now I got zzz. But what happened initially? From the beginning it did this at 2. And as I turn the pulse rate up, I get this, the buzz. Okay?
You never use that sensory
We don't.
tap?
We don't. But we use it to explain.
Okay.
We use it to explain. All right, motor on the strength duration curve.
The second.
It's really that second curve. Okay, good. All right. Now, twitch. How do you get a twitch? What parameters do you need to get a twitch?
2 to 4.
2 to 4
to 50 micro.
pulse per second or somewhere around there, and
250 micro.
250 pulse width. When does a twitch turn to tetany?
It's when the rate is increased, pulse rate is increased.
250.
17. Okay, 17 at the top, number 3. Oh, you got your little picture. Oh. Bo got her little laminated picture. Go ahead, Bo. All right, so a twitch, page 17, number 3. 1 to 10 pulses per second, brief blips for contraction. Used for motor intensity and pain protocols to get long-term relief. However, tetany sits above 15 with your contraction. Okay, it sits above. So anywhere, somewhere, let's say between 11 and 14 or so, you get that changeover from your twitch to your contraction. Because it doesn't say anything about 11 to 14. It just says 1 to 10, and then greater than 15 and above. So twitch sits even up to 10, probably even 11, 12 maybe. And then it starts to convert to a tetany. Okay, so that's how we know the difference.
So 10 is above.
Tetany is above 15. All right, we're going to come back to that tetany in a second. All right, so tetany with fatigue.
100.
100
Pulse per second.
and 250.
100 pulses per second,
And 250 micro.
250. So what we did was we had the pulse rate so high while we're moving the muscle that the muscle becomes tired. So that very high pulse rate causes, so you're moving, so I'm moving a bill, okay?
Habo.
Okay, a boo. I'm looking at a bill and I'm moving a boo. All right, I'm moving a boo, or I'm moving a boo.
Oh, let's give him
Okay?
that.
So if somebody does that the whole time they're moving it, you're really going to get tired. Thank you, Abil.
You're welcome.
I'm sorry, Abu. So tetany without fatigue is I'm just moving, or I have the pulse rate where it's not going to make that body part tight. All right, beta endorphins. That would be on page 2. Well, you know the pages? Make that a question. What page?
Easier.
All right, so beta endorphins produce. Let's see, B3 at the bottom. Produced primarily in the anterior pituitary, stimulates the A delta and C pain fibers via twitch muscle contraction. Parameters are low, so here's the low rate 10s. So in order to release the beta endorphins, we need a chronic pain protocol, which is 1 to 5 pulses per second, moderately long pulse width, which is greater than 200, so we can do 250 or whatever, microsecond. All right, and then the enkephalins are released for the conventional TENS, and that's 3A on page, or A3, small letter A, on page 2. And that's where the presynaptic inhibition occurs. All right, I will go back to that quiz. Okay, now, subluxation, what does that mean?
Partial dislocation.
A partial dislocation of that humerus that came out of that socket. Now it's hanging on those ligaments. And again, we said earlier we're going to put the pad on the posterior deltoid and the supraspinatus to help strengthen those muscles to really or decrease some of that subluxation in the shoulder. Again, we just won't be familiar with certain terms. All right, so low frequency, medium frequency, high frequency. We looked at that on the second page. So low frequency is 0.1 up to 1,000 hertz, cycles per second, whatever. And then 1,001 to 10,000 hertz is medium frequency. And then 10,001 and is, so low is 10s, E-Stim, medium is Russian, interferential, or polyphasic, and then high is ultrasound, laser, if we ever get to that. Okay.
Remember, I'm saying that I said no to it.
I hear you. I hear you, man. I hear you. We got you on tape, too. We got you on tape. All right, again, we talked about low rate 10s and conventional 10s earlier. Low rate 10s is that chronic pain protocol on page 2. Page 2?
2.
And if any of these pages you don't know, ask Celia, she can tell you. And then conventional 10s is that acute pain protocol on page 2. And the parameters are there. All right, let's look at the top of page. How am I done on time, Sam? You good? Yeah. Anybody else good on time? I'm not trying to rush through, but I want to make sure that you get it. Conventional 10s is the same as the acute pain protocol 10. It's on page 2. I don't know. At the bottom, low rate 10. And that's the chronic pain protocol. Chronic pain. Okay, the gate pain theory. What does that mean? Talks about when the pain comes in, then it gets to the neuron number 1, sits in synapses with neuron number 2, where spinal cord, and the substantia gelinosa. And the dorsal horn. Good. And then we keep running up the spinal cord. Get to the thalamus. Hey, how you doing, thalamus? We do high five with the thalamus, and then, a runner from the thalamus runs to the cortex and tells the brain, "That pain," and then they send it down. Ow! And then it hurts. Okay, good. All right. So, what is presynaptic inhibition? Presynaptic. Pre-touch. pre-connection. Before the connection, something jumps in the way to prevent that.
You skip the clover leaf.
I did?
Yeah. And the target tree.
How do I do that? All right, let's go back. Let's go back to the second column. What's a clover leaf pattern? I said, what's a clover leaf pattern? They said baby. All right, so clover leaf refers to what?
So the results of
I love it. I love that terminology. To the results
Of the
How many
baby.
results you got at home? You got 3 results at home. How many results? You got 2 results? You got 1 result? I got 2 results. I love it. You got no results? You need to get some results. All right, so here are the results of what?
Oh, baby.
of the sensitivities synapses together and then it goes to
Of Sam and his wife. All right, so we know the clover leaf refers to interferential. It comes from within that polyphasic connection, within that medium frequency connection. All right, and then we get that, y'all call the baby. All right. Target, or how many people got to the 800 or the 550?
The what?
Did you feel the baby running around?
Yeah.
Bola, did you feel it?
Yeah,
What are you talking about?
I felt it.
Where?
When they put it on your back,
Where the 4 pads, the interferential center? Did
you
you
can run the baby.
That's
All right,
it.
before we get done today, you might want to put that on so you can feel it.
We played with
Best,
the baby.
best thing to do, so if you want to treat yourself, if everybody runs out, is just put it on your leg. Put it on the cord, bam, 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 and then just get the feeling of it.
You can move it if I have myself like that.
Okay. All right. Alternate electrocytes. Where else can I put pads?
No, you skip.
Stop it!
What was the question?
Denervated muscle. What does that mean?
That's no connection with the nerve.
So there's no
CVA.
There's no connection
Between the muscle and the nerve.
to the muscle nerve. Let go. There's no connection. So somehow I have to send enough electricity, since it can't go through this, to get through the body to move that muscle still, since this is not connected. So I need how much? 300 milliseconds. Good. I don't know where I'm at either, so don't worry about it. All right. Can I go to the next column?
Yes.
Okay, good. All right, page 3 in your book, on your orange book. All right, so this was a quiz question, and it said, other than putting the pads on top of or around an area, where else can I put it and still get an outcome for relief of pain?
In the water.
Okay, so if we look on page 3, the site of pain or around the pain is one area, but we don't want that. We want over the nerve roots, okay, or the involved dermatomes along the course of a peripheral nerve, like the Hoku point. Hoku point, I'm treating the arm even though I have it on the Hoku point. Okay. Related motor and trigger acupressure points. We get, is that book 3? Yeah, we get into acupressure and electroacupressure in book 3. So we'll talk more about acupuncture and acupressure in book 3. And then the lowest points of electrical resistance. Sometimes I may not be able to put it right over top of an area because of bones. I have to move it somewhere else and around, so I may go way above and way below, and because the energy can go between the 2 pads, I can still treat the area. Okay? So, if I'm treating, let's say, a low back, I can put it, let's say, lateral hip and medial hip, and it'll get right there in the center deep. Okay, because it's not over it. It's not over it, or even right there around it, but it's far away from it.
All of it?
All of it. I put a pad here and I put a pad here on both sides.
Same channel.
Same channel. And the energy will go deep to that area in the middle that I may not, for whatever reason, be able to put it right there around it or right there over it. And I still should be able to
So
treat it.
we're crossing the spinal.
Spinal.
We're crossing the spinal cord, but we're not putting it on the spinal cord with the pad. So yes, we can do that. Yeah. All right, low rate, medium rate, high rate, or pulse rate for pens or E-Stim or whatever. All right, so if we're dealing with a low pulse rate, what numbers are we referring to? 2 to 4, somewhere around there. And if we're looking at some medium number, okay, go back. So 2 to 4 might work well with what type of treatment? Chronic pain, providing that we have the pulse width where we're supposed to have it. All right. Some middle numbers for pulse rate might fall where? 50 up to 70. Good. 50 up to 70. And I can treat what with that?
No, education.
Muscle re-education. Good. I can do that. Okay. And then, what's high? What's considered high? 80 to 100. And I can treat what with? I can treat basically two things with that. One could be a good thing, one could be a bad thing. But I can treat one sensory acute pain, or I can treat muscle spasm for fatiguing the muscle. So if I do, let's go back. I have 100 pulses per second. I need what pulse width to treat acute pain? 50. I need what pulse width to treat a spasm? 250. Pulse rate the same, but the pulse width is different. And based upon the rate can be a good thing, or the rate can be a bad thing. Now, we mean bad thing is we want it to fatigue, you know, but that's what it's going to do. Just make sure you're not fatiguing something that you shouldn't be fatiguing. That's the only thing. So don't place it at 100 pulses per second for quad lag, because that's not what you want. Okay, that's not what you want. All right, pulse width. What could be considered a low number for pulse width that we use? 50. All right. And then midway would be probably about 250 if we want to say something in the middle. And then high, 200 would be somewhere in the middle. Well, not really the middle, but we can say a mid-range. And then 250, 300, even if you're looking at page 62, 400, we can go up to that for a pulse width, as long as it's in the microsecond range, and we can still move. So, 50, 200, 250, 300, and above. Okay, page 70. Let's go to page 70. Probably answer some of this. Let's look at page... Let's look at number 13. If patient is set up with 2 equal-sized electrodes on channel 1 of a biphasic machine, what will the patient feel when it's on continuous? Current flow between the pads. So you'll feel them equally pretty much in each pad. What will happen on a biphasic unit when it's on reciprocate?
Try it again.
Yeah.
Alright.
All right. Reciprocate. What is going to happen? I have a pad here. I have a pad here. They're equal size. I turn this machine on reciprocate. What is it that the person is getting? Intermittent energy. So it comes on this one. It's trying to go to that one, but that one is not on the body. Okay, so it just bounces back and forth. So if you had, for example, you had this on the anterior tibialis, and you had that on the gastrocnemius, the foot will go. If this was on the gastrocnemius, you would get the pumping. If it wasn't on the gastrocnemius, okay, good, you would get dorsiflexion only, and nothing in between. What about on surge? So you really get the same thing. Okay. So on reciprocate, you get dorsiflexion because it's on reciprocate. It's trying to go to the second channel, but it's not on the body. On surge, you just get the same thing. So you basically get the same thing. You get the same outcome. Okay. All right, good for page 70. All right, now, IFC. Page 21. What do we need in order to have good comfort and less resistance? Increased frequency. All right, so if we look at letter A, low skin impedance equals resistance. Impedance is inversely proportional to frequency. If you increase the frequency, you decrease the skin resistance, you increase the comfort. So if you have the hertz, pulses per second, cycles per second, if you have that high, you'll have less resistance, you'll have great comfort. However, what's the downfall that we talked about with that? With a high frequency. Fatigue. Good. All right, so we have fatigue. Now, we don't want fatigue. All right. However, why is medium frequency effective with its high frequency?
Goes deep.
It goes deep.
They synapse to each other, the two channels.
The two channels that have alternate frequencies synapse. They hit one another, so they're able to go deep. They won't be effective for treatment, but the outcome will be effective for treatment. Good. All right. What are the electrode types, or best preferred types? Types. Carbon. So carbon electrodes, because they're more dense, so they can handle the strong intensities.
What are they called again? The thin
Carbon.
ones.
Oh,
The thin
stickies?
ones.
Just the stickies?
No, the ones you use for the self-fixation, they were thinner. Are
These?
they also carbon?
These are carbon
Yeah.
too. They're just,
Oh,
yeah.
it's the same?
They're carbon too. Yeah.
Because it can handle what?
The electricity, the current. Because remember, you're sending 5,000 in this example, but you're sending 5,000 hertz through that. So you don't want the person to say, "Oh, that hurts." So if you have a lot of pads here that can handle all of that energy, and you won't have all of that going out. Okay. Same size pads with same intensity. I gave you a handout on interferential, and we talked about pad sizes. All right, so. Intensity on the machine is set equally between two channels. What do you get? Where is the vector? in the center. And it goes so the
Isn't it
vector
parallel? Isn't it parallel
parallel to the
positive?
positive, it could be the negative, but parallel to the positive pads. Now, if same size pads with different intensity,
Goes to the higher.
it goes to the higher intensity. So if for whatever reason it is channel, let's say that's channel 2 for example, then it's going to go back and forth within that channel level. Okay?
Wait. You said it's for the higher
Yeah, so if channel 2 has been set to be higher than channel 1, then the vector is going to favor channel 2 and focus more in that range of channel 2 moving back and forth. If I have different size pads, where is the vector going to tend to stay closer to?
The small size.
Good. This would be a good treatment for pain in the paravertebral muscles of, let's say, C3. Why? Because then I could put the pad
Small.
right there underneath the skull. I can put two teeny ones right there. I can put some large ones here on the upper trap. The vector is going to stay closer to the smaller pad, and I can treat right up there. What would I normally have to do in order to get that to be in the center? I would have to put an electrode on the brain, right? If I had equal size electrodes, I would have to have them on the brain in order to have the vector in the center. But since I want the vector to be closer to the skull or to the occiput, I need to make my pad smaller so the vector stays closer to that area. Okay, assorted concerns. All right. Shock. No. Go back. Problems for no current or low current. Get your hand out on that. Because you've had it before. I know you've seen it before. Low current or no current. And this is what you really want to focus on. All right, so why might you not get some current? Why is it that it might not come on?
The machine's not on.
Ain't on. Ain't plugged up. Your leads, wrong. Somebody had, what machine was that? It was this one. Everything was set perfectly, but this was in channel 2. The machine was reading channel 1, but it wasn't necessarily reading channel 1 because this was in there. It was just, it always reads channel 1 first, it reads channel 2 second. All right? And it was sitting in channel 2, and we turn and turn and turn and turn and turn and turn. You feel it? You feel it? Do you feel it? Let me know you feel it. You feel it? You feel it? They never felt it. And then we realized, oh, it's sitting in channel 2. It's not sitting in channel 1. All right, so that's very important. All right, what's some more reasons?
Small pads?
Small pads. You can feel it, I would hope. But sometimes it's not the pad as much as it is gel. Okay. So make sure that you have enough gel to treat the area, or your pad is lubricated enough, or the pad is secure to the body part, nice and firm to the body part. Okay. So just look at some of those on the handout page that I gave you, and then that'll help you so why you're not feeling something. Okay. All right, let's see. Shock. Why? Why is it that the person got a shock?
They cut off the circuit.
How did they cut off the circuit?
They take off the pad.
They took off the pad. I don't know why they do that, but you know, they took off the pad. So you had two active pads on, and then with the intensity was on, they were feeling it fine. Or you had one active pad on and one dispersive pad. They was feeling it good from the active pad, and then either one fell off. Let's just say it fell off. We won't say it. Yeah. And then one fell off or came loose, and oh, and they got a shot. All right. What's some other reasons? Turn up the intensity for a surge, most likely, for during the off time. Didn't see the light, didn't pay attention to the light, turned it up, oh, I said, oh, and then they jumped like, say, oh my God, they have a fit. Because you were turning during the off time. You say, he's crazy. What else can we do?
PR or PW.
Turning up the pulse rate.
With a high intensity.
Oh, I'm sorry. Turn up the PR or the PW. Okay, PR, put it down. PR or PW. That's what the bill said. Huh?
What's the second one again?
I don't know what we say. What we say? I have no idea.
Pulse rate or pulse width?
Pulse rate or pulse width? Turning that up.
No, turn up during off time.
Turn it up during that time frame.
Another one?
Turn it up during